breast reconstruction. 1 in 8 women get diagnosed with breast cancer. Unfortunately, it's that common. I think people think that breast cancer is a rare disease, and it's not. So 13% of the public will get diagnosed with breast cancer. And so when you get a breast cancer diagnosis, there are different ways you can go about treating that. One is doing what's called a lumpectomy or a partial mastectomy or a total mastectomy. And that means you're removing all of the breast. Now, the approach kind of depends on the patient, it depends on their anatomy, it depends on the cancer. And that's a discussion you would have with your breast surgeon, who's a general surgeon who actually removes the cancer. Plastic surgeons get involved to help reconstruct those defects that are created from the cancer removal. And you can do that in 2 ways. There's what's called partial breast reconstruction, and that's something we do to rearrange tissue to try to make the breast have a better shape in the area where the breast tissue was removed. And then there's total mastectomy breast reconstruction that we can do. And with total mastectomy breast reconstruction, there really are kind of 3 main approaches that you can use. And if you look at the screen here, the most common technique we use is what's called a tissue expander. And a tissue expander is basically an empty balloon, and it's an empty balloon that has a port on it. And this port is something we can use to fill with saline. And so with reconstruction, you can do it immediately, and that means at the time of the mastectomy. So the general surgeon removes the breast tissue, and then I come in and I do the reconstruction. Or you can do it in a delayed fashion, meaning you have your mastectomy, you heal up, and then you come back at a later date and do the reconstruction. Ideally, we like to do immediate reconstruction if you're a candidate, and that's a discussion you have to have with the general surgeon. And so if you do reconstruction, the most common technique is using a tissue expander. About 70 to 75% of women who have breast reconstruction will use a tissue expander. And a tissue expander is basically an empty balloon that, again, it has this port. And this port is something that you can put fluid in. And so after the tissue gets removed, I come in and I sew this tissue expander in onto the chest wall. And I can put this tissue expander in 2 locations. I can put it underneath the muscle on the chest wall, the pectoralis major muscle, or I can put it on top of that. Most of the time now I tend to put the expander on top of that muscle. And that decision is really based on a number of things. One is how is the perfusion of the mastectomy skin flap? And so this is an important concept, because when you do a mastectomy, you're removing all of that breast tissue, and what happens is the blood supply that is going to the skin on the chest wall gets divided. And so upwards of about 20% of women who have mastectomies can have wound healing issues due to that alteration in blood supply. Now, when we're doing this operation, there's a device we can use called SPY vascular imaging that allows us to actually evaluate the blood supply to the mastectomy skin flap. If the blood supply looks good, then I will typically put the expander on top of the muscle on the chest wall. If it's compromised, I tend to put it underneath, and the reason for that is the muscle can provide some blood supply to help that tissue heal. In both situations, I use a product called acellular dermal matrix. And acellular dermal matrix is a cadaveric dermis, so simply put, it's skin from a dead person. And we use that to help cover the expander. It acts as a sling, or it helps create a pocket to hold it in place. In that product, the body's own tissue grows into it. So when you go back later on, it has become vascularized. And so it's been used for many, many years in breast reconstruction. It's a safe product. It's tried and true. It's been researched and published many, many times. And so you put the expander in, you cover it with the acellular dermal matrix, and then while you're asleep, we usually put about 30 to 40% of the volume inside this expander that you'll eventually have. So when I place the tissue expander in, if we do it in an immediate fashion, I'm doing it at the time with the general surgeon. If we do it in a delayed fashion, we're doing it at a later date. But you put the tissue expander in, you cover it with that acellular dermal matrix, and then I typically put about 30 to 40% of the volume in this expander that you'll eventually have. And you have 1 or 2 drains, and the drains are usually in for about 2 weeks. after the drains come out, as long as you're healing well, this has a port with a magnet in it, and I can locate that port on the chest wall because of that magnet. And then in the office, we clean that skin off and we put a needle into that and we fill it with saline. And we do that every 2 weeks. Most people average about 3 to 4 expansions, so that takes about 6 to 8 weeks. And then once you're fully expanded, we let it sit there for about 6 weeks. And then you go back for a second operation where you take the expander out and you put in a much softer implant. So that's operation number 2. And then if you want a nipple reconstruction, that's something you do later on, about 3 months after that. Now the timeline for that reconstruction can vary depending on the patient's need for chemotherapy and or radiation therapy. And that's a discussion that we have depending on what the oncologist recommends for further treatment. So with the tissue expander placement, we can place it under the pectoralis major muscle or over the pectoralis major muscle. And really over the last probably 5 years, most plastic surgeons are placing the expander on top of the pectoralis major muscle. And there's been a bit of a transition. And for years we always placed that expander underneath that muscle on the chest wall. And it was very tried, it was true, it worked, but one of the big complaints that mastectomy patients had is animation deformity. Because when you do a mastectomy, the mastectomy skin flaps are very, very thin, and that thin flap would scar right down to the pectoralis major muscle. And so when those patients would do activities, when they would work out, you could see a lot of movement of the expander and the implant when that is eventually put in there. And that's something that's very hard to camouflage. And so by putting that expander and then the eventual implant on top of the muscle, that animation deformity tends to go away. And the reason that we can do that is we also have better implants now. And so the implants that we're putting in there tend to be a highly cohesive gel implant, or what we call our gummy bear implants. And these newer generation implants have a lot less rippling than older generation implants. And so overall the outcome tends to be a lot better. You don't have the animation deformity associated with that muscle movement, and you don't have the pain associated with the implant underneath the muscle that is much more common in women that have had mastectomies relative to women that have had breast augmentation. So the second phase of breast reconstruction is where you take the tissue expander out, and I tell all my patients tissue expanders are like a rock in a sock. They're very hard, they're very firm, but they are temporary. And that second operation is an easier operation. You don't have drains associated with that. And you take the hard expander out and you put in a much softer implant. And I typically go through that same incision that was used to remove the breast. You put the implant in, and again, this implant is a lot softer than the expander is. With that second stage surgery, we often do what's called fat grafting. And that's where we take some fat from the belly, the hip, the flank, and we take that fat and we layer it over the top of the implant to give it a little bit more coverage. And it just softens the reconstruction, and it makes it so that the implant is not as visible, or you don't have as much rippling. You get fairly beat up from that because you get bruised from the liposuction part of it, but it's an adjunct to the operation that just gives you that much of a better result overall. The third phase of breast reconstruction is nipple reconstruction. Nipple reconstruction, I always tell my patients, a breast without a nipple is kind of like a face without a nose, and so it just looks a little bit odd. Most people end up doing nipple reconstruction, and you can do that in 2 ways. One is you can get a tattoo, which is an option. It's the easiest option, but probably not the nicest option. And the second option is you can actually build a nipple and areola. And the way that you do that is you take some skin, and that skin is put on to reconstruct the areola, and then the nipple itself you reconstruct from the mastectomy skin flap, where you lift this tissue up and you rotate it on itself, and it actually creates the nipple. And I do think it's one of the most important parts of the breast reconstruction, because when a woman gets out of the shower, she looks at herself, it just gives her a sense of being complete. And again, when you have that scar from the mastectomy and you don't have a nipple, I think people feel like something is missing, which it is. And so the nipple reconstruction really helps kind of complete the process. Now, there are women that, due to their type of cancer, due to the size of their breast, or women that have genetic susceptibility to breast cancer, such as BRCA, who are candidates for what's called a nipple-sparing mastectomy. And with a nipple-sparing mastectomy, you're keeping the nipple on the breast, and so they can skip that last step. So a nipple-sparing mastectomy is kind of the ideal option if you're a candidate for it. And again, that's a decision you have to make with the general surgeon based on whether you have cancer or whether you're doing this for prophylactic reasons due to, say, being BRCA positive. With breast cancer, there are a smaller percentage of women that will be tested and they'll be found to be a carrier for a gene mutation that can increase the risk of breast cancer. The most commonly known one is BRCA. So you have BRCA1, BRCA2, but there are a number of other mutations that can increase your lifetime risk of breast cancer. And so in most of those women, they will recommend doing prophylactic mastectomies. So you're removing the breast before you actually have a cancer. And many times in those situations, the patient will be a candidate for a nipple-sparing approach, and you'll do all the things we talked about, but you don't have to have the worries of having chemotherapy or radiation therapy postoperatively. So depending on the results of your pathology, and so when you do the mastectomy, the breast tissue goes to a pathologist, and usually the general surgeon will sample the lymph nodes. If you have positive lymph nodes or you have a positive margin, often patients are going to require chemotherapy or radiation therapy. In the most common situation, people will do chemotherapy first, and then they'll end up doing radiation therapy. If you have chemotherapy, I can still expand you in the office, but we can't operate on you until you're done with chemotherapy. If you have to have radiation therapy, that typically lasts for about 6 weeks. And when someone has radiation on their chest wall, you typically cannot operate on it for about 9 to 12 months. And the reason for that is radiation leads to permanent changes in soft tissue. And radiated tissue doesn't heal well, it doesn't stretch well, and it doesn't fight off infection very well. And so if you operate on radiated tissue too soon after finishing radiation, your chance of having breakdown, infection, and ultimately losing your reconstruction is a lot higher. Now, if someone has radiation, you can get hardening around the reconstruction. And so the implant that is in there can form a very thickened scar capsule. And that scar capsule can squeeze down and it can push the implant upwards, and it can lead to a painful breast or a misshapen breast. And so when patients develop that, there are different ways to deal with that. One is you can remove the scar capsule and you can sew in a piece of acellular dermal matrix. The second, and probably more common, is to bring in healthy, non-radiated tissue. And there are really kind of two ways that you can do that. One is you can take a muscle from your back, called the latissimus dorsi musculocutaneous flap, and you bring that around to the front, and you bring skin from the back. And what it does is it brings in that healthy tissue, and then you put the implant underneath that. The second option is to take tissue from the belly, where you take that tissue and you transfer it up, and you most often will hook it into a blood vessel in your chest wall called the internal mammary artery and vein. Now that's a very big operation relative to the other two operations. But again, if you have to have radiation, due to the damaging effects of radiation, you often have to do other surgeries to try to ameliorate the effects of radiation. Partial breast reconstruction is an option for patients to have reconstruction after having a lumpectomy or a partial mastectomy. And in that operation, the general surgeon removes a lump where the cancer is. And historically, the patient would then go on to have other treatments like radiation therapy, and then they would come and see the plastic surgeon a year or two later, and they would have a defect or a concavity in their breast, and they'd want that improved. And one of the things that we've started to do is combine the operation and do what's called oncoplastic surgery. So the general surgeon does the lumpectomy or the partial mastectomy, and then I come in and I rearrange the tissue and do what we do when we effectively do a breast reduction or a breast lift. And in this operation, what we're doing is, depending on where the cancer is, the general surgeon will come in and remove the cancer, and then I come in and I do this anchor-shaped pattern. And what you're doing is similar to something that we do when we do a breast lift or a breast reduction. And so you're making an incision around the nipple, and the area in blue is where you can preferentially remove skin and or breast tissue. And then you lift the nipple up so that when it comes together, you end up with a scar that goes around the nipple, down the fold, and then along the inframammary fold. And so it's a combination operation that allows us to reshape the breast and at the same time remove the breast cancer. So breast cancer is very common, unfortunately. And for women that have to have treatment for that in the form of a partial mastectomy or a mastectomy, can undergo reconstruction. And reconstruction is very important really to make women feel complete again, and that's really in all facets of their life, physically, emotionally, and psychologically.